COPD and asthma. So we're going to be right back. Welcome back. What we're going to be looking at over the next 15 or 20 minutes or so is classifications of severity, assessment of COPD, the risk for exacerbation, combining assessments, the comorbidities, the differential diagnosis. We're going to continue on this theme. What we want to do is make sure that you're getting a complete workup so that we're looking at the other potential causes. We want to have a differential diagnosis. What are the other things that might be bringing up purulent sputum, making you cough, making you short of breath? And then what are the therapeutic options? How can we reduce your risk? How can we help you to stop smoking? Are there surgical treatments? And then are the pharmacology and other medication treatments? So smoking cessation is the greatest capacity to influence the natural history of COPD. If you don't stop smoking, you are looking at a relentless downward progression of dyspnea, cough, purulent sputum, and by stopping smoking, you can at least arrest that or maybe even improve your symptoms. So our job as healthcare providers is to help you through this. There is pharmacotherapy, there are nicotine replacement patches, and these will reliably increase that long-term abstinence. Heroin and cigarettes, recidivism is the biggest problem. So through our public health department, through the American Lung Association, through this program, we're going to provide you with the resources, including the pharmacotherapy and nicotine replacement, if that's what it takes. And we need you to have you stick with it. Now the other thing, through the Better Breathers Clubs and other resources that we'll be developing, we know that regular physical activity needs to be encouraged. You need to remain active. So the most important thing here is going to also be seeing a physician who's going to prescribe appropriate pharmacologic therapy. Just going in and getting an albuterol inhaler at your emergency room whenever you feel sick, there are other medications involved that can help to control symptoms and really reduce the severity, reduce the amount of time that you spend in the hospital or return to emergency rooms. The medications, though, do not prevent the long-term decline. You must stop smoking. The other things that we can do, we want to make sure 100% of people have done this, and that is influenza and pneumococcal vaccination. We need to have it. The higher dose influenza vaccine, the second type of pneumococcal vaccine, and as we age, like myself, we may need boosters if you received it earlier in life. What we know about cigarette smoking is if the doctor can spend as little as 3 minutes talking to you about this, encouraging you, doing motivational interviewing. It has to be important to you that you stop smoking, and then for you to look at your day. How can you not have cigarettes in the house? How can you avoid dangerous places where you're going to start smoking again? And then working with you to see how those pharmacologic therapies, the gums, the inhalers, the nasal sprays, the transdermal patches, the sublingual tablets, the lozenges, and then there are other medications you can take by mouth, one of which was used in depression, but it turns out it's very helpful for people who want to stop smoking, and they're more effective than placebo. So our job as physicians is to ask, advise, assess, assist, arrange. So we really want to, if we don't ask, don't tell, we need to ask. We need to identify tobacco users. We need to advise them, really urge people to stop smoking. We need to assess, are they willing to stop smoking? And that's that motivational interviewing. It's got to be the patient's decision. You can help them. You can't do it for them. Then we need to assist them by prescribing medication or continued counseling, making interventions through community groups or telephone numbers. And then arrange, we need to schedule that follow-up contact. In terms of reducing risk, as a community, as we head out as physicians in the community, as community members, we need tobacco control policies. We need to control it in bars, we need to control it in movie theaters, in public places, and it needs to be clear and consistent and repeated non-smoking messages. This needs to come from our city councils, needs to come from our county government, needs to come from your medical association, American Lung Association, Livingston Visiting Nurses, everyone involved. We need to make this clear, consistent message. And then in the workplace, So we can do this by eliminating smoking in the workplace, having people smoke out by the trash can. Well, we want them out of our way. We want people to stop smoking and not being exposed. Then indoor air pollution from biomass fuels that we've talked about. This needs to be included with our advice to our farm workers who may not have a heater, who may be burning biomass, burning for cooking and heating in a poorly ventilated setting. Then we need to advise patients to monitor air quality measures. So as we look at the therapeutic options, we have a number of them. We have what are called the beta agonists, and those are there to help open up, relax the muscles around your bronchial tubes. They can be short-acting or long-acting. We have what are called anticholinergics. So as you've affected the nerves in the lungs, can we calm those down so they don't tell your lung to go into spasm? There are combinations of telling the muscle to relax as well as telling it not to spasm. We have combinations in one inhaler. We have what are called the methylxanthines, which are more from my day. These are the theophylline, the Theodor, the Slobid, that used to be a lot more popular 30 to 40 years ago. Inhaled corticosteroids can be of benefit, particularly if someone has asthma, but a combination therapy of long-acting beta agonists, a long-acting form of medication that relaxes those muscles, as well as inhaled steroids, seems to be the most effective. Taking steroids by mouth may be helpful for short periods of time, but we don't want to cause cataracts and collapse of the bones of our spine and problems with sugar diabetes. And then phosphodiesterase 4 inhibitors. These are some of the newer medications that someone, as an adult pulmonologist, if you have the stage 3 and 4 disease, these are the drugs you may be using. So again, bronchodilators are central to COPD. They're prescribed oftentimes as needed to prevent or reduce symptoms. You might end up using them before you go up the stairs if you're severely affected. These drugs are the beta-2 agonists, the anticholinergics, the theophylline, or a combination of these. But these things depend on the availability, what's on your formulary. And in the countries we travel, we've been to Peru, we go to the Honduras. All I may have is a form of beclomethasone and a form of albuterol, and that's it. So we make do with what we have. We're a great advantage here in the United States. Now the nice thing about the longer acting ones is they're convenient. Just twice a day, people need to remember to take them. Sometimes I'll duct tape them to people's toothbrushes. We need to wash our mouths out after, get the steroid out of the mouth. We want it in the lungs. And they are known to reduce these exacerbations, these MAID worsenings, reduce hospitalizations, improve symptoms and health status. And so by combining the two, the long-acting beta agonist and the steroid, we can see a great deal of improvement or at least control of symptoms. Regular treatment. So this is when my patients come in the office, I go, oh, are you using your medicine? Well, you know, I use it kind of when I feel bad. I go, oh, did you come here in a car? Why, yes. Did you wear your seatbelt? Yes. Oh, I'm sorry, did you wear it because you got in an accident? Well, that's really what we're looking at. We need to use these things ahead of time. Think of them as the seatbelts for the lungs. There is an increased incidence of pneumonia associated with these, and if you have a fever and a cough, even if your symptoms have been controlled, you need to be seeing your physician right away. And stopping the medicines because you can't afford them, or you didn't make it to the physician's office, or it was time for a refill and your doctor wanted to see you before refilling the medicines. This is where the case managers hopefully would be assisting you, because we need for you to be taking your medications. So again, the combination therapy is the most effective. We have that increased risk of pneumonia, and adding the two together appear to provide additional benefits. Again, chronic treatment with prednisone, steroids by mouth, is contraindicated. There's an unfavorable benefit to risk ratio. Now, in patients with very severe disease, and severe disease, the GOLD 3 and GOLD 4, with a history of exacerbations, chronic bronchitis, coughing up yellow, coughing all the time, there is an additional medication available now, roflumilast, which can reduce exacerbations, particularly in those patients who are treated with oral steroids with the prednisone. Theophylline, which is in tea, the equivalent to it is in caffeine. does relax the bronchial tubes. The side effects, though, can be faster heart rate, intestinal distress, faster movement of the intestine, and it has a modest effect compared to other medications. When we take a look at influenza vaccine, there's where your money is, especially for Gold 1, Gold 2. That may be most of what you need is to prevent serious illness. The use of antibiotics, other than demonstrated bacteria down there, really are not going to be indicated. We can bring up mucus. It's not necessarily infected. We don't want to be culturing more and more resistant bacteria. Now, for patients, those 100,000 in the United States who have the alpha-1 antitrypsin deficiency, who had onset of COPD before age 45 or a family history of young onset, this medication, the alpha-1 antitrypsin augmentation therapy, is very helpful. Mucolytics, a lot of people like their Mucinex or like their Tessalon pearls, really doesn't seem to help a whole lot. Antitussives, people become Phenergan with codeine dependent or Tussinex dependent. It's really not very helpful. Really, you want to get at the underlying cause. People have tried vasodilators, things to open up the blood flow through the lungs. Again, not very effective. So nitric oxide is really not something that's going to be helpful in stable COPD. But people do benefit from exercise training. So this is a way to get social, to get out, walking club, steps. If you're going to get a step ahead of dyspnea, inability to get a good breath, to get a step ahead of fatigue, an exercise training program is going to be essential. In general, especially with the Better Breathers clubs, we try to be pretty intensive for 6 weeks, and oftentimes like soldiers in a foxhole, you get to know each other and continue to support each other in terms of exercise. If you can maintain it at home, then you can maintain that health status above that 6 weeks where you participate in the exercise program. Oxygen therapy, you see people with cannulas carrying oxygen tanks or with oxygen concentrators. For patients with chronic respiratory failure, people who are in that gold stage 4, it can be very helpful. It's an expensive intervention, but if it gives someone less dyspnea, less feeling where they can't get their breath, can improve their exercise around the house, so much the better. I have patients who use something called Breathe Technology, non-invasive oxygen-powered ventilation. And I have one young man who's getting set for a lung transplant. This has allowed him to keep in physical condition to allow him, until we can find a set of lungs for him. So in a selected subset of patients, this ventilatory support can be very helpful as well. So in summary, we've looked at additional investigations and differential diagnosis. We looked at the different therapeutic options and how to reduce risk, especially smoking cessation. We're going to talk about surgical treatments and other medication treatments and Ventura. We're going to be right back. Welcome back. Well, we've been talking about additional investigations and differential diagnosis, therapeutic options and risk reduction, smoking cessation, surgical treatments, and other medication treatments. So really, if we start with how do we manage stable COPD, what are our goals of therapy, how can we avoid risk, what pharmacologic therapy can we intervene with, and non-pharmacologic therapy such as exercise, how can we manage exacerbations, and what are the consequences when you have a worsening of disease, how can we assess that, how can we treat that. So really the main thing is identification and reduction of exposure to risk factors. We got to get away from cigarette smoke. We have to watch exposure to infection. And if we're going to prevent and treat, that's really going to be the cornerstone. So if we take a look at individuals, you have to look at your own life. You can't just be looking at a computer screen and have it suggest exactly what you do. We need to know where you're going to be. We also need to take a look at what causes your airflow limitation, what causes that contraction, and we want to make sure that we're getting a step ahead of these exacerbations. And with this grant, the idea is to do that with case management and these community health workers. Everybody will benefit from rehabilitation, maintaining physical activity, and we use the pharmacologic therapy really to reduce symptoms, reduce the frequency and severity of these exacerbations, and really improve overall health status and your ability to tolerate exercise. So to do that, again, the long-acting beta-2 agonists, the ones that relax your lungs for 12 hours, the cholinergics, the anticholinergics, again, not causing the lung to contract. We prefer those over the short ones. So people you see sucking on their inhalers all the time, really we have alternatives where they don't need to do that. For some people, it's a placebo. Well, we don't want a placebo. We want medication that works, and we want it to work for your life. And so taking it twice a day is better than depending on that short acting where if you've lost it, oh my gosh, you're going to be in real trouble. So if there's a high risk of exacerbations, we want these long-acting medications. Now, long-acting therapy just using the steroids by mouth is not recommended. Just using an inhaled steroid without that medication to open up the bronchial tubes is not recommended. And again, that roflumilast, the phosphodiesterase 4 inhibitor, if you're down there with the ability to move air through your lungs at less than 50%, you've got chronic bronchitis, it can be very helpful in terms of those with frequent exacerbations or worsenings. So really what we're looking at, we want to reduce symptoms and reduce risk. We want to relieve symptoms, improve exercise tolerance, improve health status. We want to prevent this disease from progressing. I can't make it better, but I can prevent it from progressing. I can make your symptoms better, I can reduce them. And then we want to get a very early prevention and treatment of exacerbations or worsening. And we want to prevent death. We want to have a good life. We want to prevent death. And by making these interventions, we can reduce mortality. So, avoiding risk factors, smoking, indoor pollution, occupational exposure, get your influenza vaccination, and your pneumococcal vaccination as well. So when we look at the non-pharmacologic interventions, again, smoking cessation, physical activity, flu vaccination, pneumococcal for mild disease, really that's what your doctor is going to be recommending. As we move into the worst patient group, if you remember our little chart from before, patients who are having problems with breathlessness, who are having exacerbations, smoking cessation, big part of it, physical activity, a big part of it, flu vaccination, big part of it, pneumococcal vaccination, big part of it, pulmonary rehabilitation, but we really need to include the medication on a chronic basis, long-acting medications that fit in your life. So if we take a look at the different types of medications, the antimuscarinic short-acting, the short-acting beta agonists, those are really for just symptoms, and so when people have mild disease, they may be sufficient. As we move into that category B where it's beginning to affect your life, now we really want to start looking at long-acting muscarinic antagonists. We want to look at long-acting beta agonists and combining them with the steroids. As we move into those people who are having exacerbations, bringing up sputum, FEV1 is less than 50%. Now we need to be doing that very aggressive pharmacotherapy, and we have alternatives, and this is where it's time to meet with your pulmonologist and really look at more and more combined medications. As we hit D, the ones at higher risk, then that inhaled corticosteroid plus the long-acting beta agonist and a long-acting muscarinic antagonist is essential therapy. There are alternative options, but really these are the things we need to introduce into your life. So again, we're looking at symptoms. If your symptoms are at a combined scale of less than 10, your feeling of breathlessness is 0 to 1, you're in pretty mild disease, and as you see on the screen, these are the therapies that are recommended. Now, these are the alternative choices as well, so that if your insurance company or the formulary doesn't cover the exact medications that fit into those categories, these are some alternatives. And for some people, it's a matter of, well, we had one medication that worked very, very well, but it tasted like licking a car bumper. And so we complained to the manufacturer, and they put mint in it. So now it tasted like a mint-flavored car bumper. So some of these medicines, they may be hard to take, may not taste right, And so we need to look at these alternatives as well. Other possible treatments, again, especially as we move to other countries, we may be stuck with a very limited set of medications. And so we start looking at these alternatives, the carbocysteine, and short-acting beta agonists, theophylline, because we are so limited in the medications available. The expense to the government as they try and treat these people with a very damaged economy, much like we'll see in the Honduras and Nicaragua. For them, there's a very limited set of medications. So how do we define this exacerbation I keep talking about? So it's an acute event, so it's not like your everyday life. It happens suddenly, acutely. You have a worsening of your symptoms, and it's beyond the normal day-to-day variation. Some people have good days, bad days. This is going to lead to a change in medication. So you need to up your therapy when you have an exacerbation. You may know it because, oh, I had a cold and I know, gosh, 3-4 days later, it really settles in my chest. Or for the last, about 2 weeks ago, I had a cold. I'm bringing up more mucus. I'm having more problems with dyspnea. I'm starting to lose weight. You don't go to McDonald's and order a mucus burger. You cough that mucus up and swallow it. Your appetite goes away. So if we have these COPD exacerbations, again, oftentimes it's a viral upper respiratory infection. Antibiotics aren't going to be helped. The diagnosis, you need to have, again, that primary care doctor. There's an acute change in symptoms, and that's what you need to communicate to your physician. We want to minimize the impact of this exacerbation on your life and prevent the development by getting a step ahead. If you have started smoking again, if you're not in rehabilitation, if you're not filling your medication prescriptions, that's part of the goal of a physician visit. So again, if there's an exacerbation, we may end up using more of those short-acting beta agonists and on top of your usual long-acting beta agonist inhaled corticosteroids. Maybe this is time for prednisone by mouth if there's an acute exacerbation, but again, we want it for a very short period of time. We want to improve recovery. If there is purulent sputum, then we want the antibiotics can improve recovery time, improve lung function, and get you back to where you need to be. If there is in the emergency room or in the physician's office, they check your level of oxygen with a pulse oximeter. It's reduced. You may require oxygen. And that can prevent an early relapse, a return to the hospital. A hospitalization nowadays ends 30 days after you've left the hospital. We have to pay attention to you not returning to the hospital, and this is the best way to do it. And oftentimes they can be prevented. I tell my patients this time of year, I've got Christmas, I've got Thanksgiving, I've got relatives. If there's, put a Kleenex box by the door. If it's green, tell people not to come in your house. So again, the consequences of these, it's not just a matter of some numbers on a piece of paper. It's impacting your quality of life. It's impacting your symptoms, impacts that movement of air through your lungs, the lung function. It costs money. You're missing work, you're in the hospital, increasing the cost of medications. And people in gold stage 4, particularly women, it increases mortality, these frequent exacerbations. And frequent exacerbations lead to an accelerated lung function decline. Your lung function is going downhill. So again, in the hospital, they might do an arterial blood gas. So if the level of oxygen is sitting there below 88% on our pulse oximetry or below 65, then you're going to need extra oxygen and you're going to need to be able to return to room air. So we don't want you to go into respiratory failure. An elevated level of carbon dioxide, particularly if you have long-standing disease. Giving oxygen actually may not be helpful. That may be, that lower level of oxygen may be what's driving your respiratory drive. Oftentimes people get a chest x-ray, more to exclude alternative diagnosis. You can have a worsening of symptoms without any changes on the chest x-ray. EKG, particularly if you're older, if you're in congestive heart failure, an EKG can be helpful, or picking up a new silent heart attack. A blood count to see whether your oxygen levels are so low that your body's making extra red blood cells. Purulent sputum, this is that green, thick mucus coming out, and it may be time to start antibiotics or culture it if you've had frequent antibiotics. biochemical tests, so the comprehensive metabolic panel to help detect electrolyte disturbances, sodium, potassium, chloride, see if your blood sugar is elevated, or signs of poor nutrition. During an exacerbation, spirometry is not that helpful. As we recover, it can help guide us in terms of when it is time to go home. So in terms of treatment, oxygen, to keep that oximetry 88 to 92%. We're not looking for 100%. Again, that can shut down your respiratory drive. The use of bronchodilators and the use of steroids, all those in combination can reduce the length of hospitalization and get you home with more speed. The oxygen may be used at home as well. It may be that for a short period of time you'll need to be discharged on oxygen. So antibiotics, again, with a respiratory infection due to a virus, are not going to be helpful. But if there's increased shortness of breath, more sputum, and more purulence, this is where antibiotics may be helpful. And some people may require mechanical ventilation. This is where we try not to put tubes into the trachea. We try and stay away from invasive ventilation. And this is where just an external help, what's called non-invasive ventilation, a mask ventilation or ventilation through your nose, can improve respiratory acidosis, can allow you to rest, let your respiratory rate reduce, allow you to rest, decrease that feeling of I can't get my breath, and decrease complications and the length of hospital stay. Non-invasive ventilation can decrease mortality, and really, again, that intubation, that's really a downhill course and something we want to stay away from. So again, in terms of hospital admission, if you or your caregivers, your son, your daughter, if you're having a marked increase in intensity of symptoms, we need to let people know. You may be heading towards the hospital. If you're gold stage 4, you have severe underlying COPD. Doesn't take much to get close to the table and fall off the edge. Onset of new physical signs of fever, or more rapid heart rate, more rapid respiratory rate. And if you've seen your doctor and it's not getting better after several days, you may need to spend some time in the hospital. If you have other problems, lung cancer, diabetes, heart disease, these things, this COPD exacerbation may be enough to put you in the hospital. If you have a history of frequent exacerbations, frequent worsenings, you may need to spend time in the hospital. Older people, very fragile. It doesn't take much, and particularly if you're not around other people and you don't have caregivers, sometimes it's good to spend a little time in the hospital, having that case manager work with you, but particularly it's with this increase in symptoms. So if you have insufficient home support, that's really what we're trying to do with the visiting nurses and the case managers. So in summary, we've been talking about managing stable COPD, the goals of therapy, avoiding risk factors, the pharmacologic therapy, the non-pharmacologic therapy, and managing exacerbations. So there's consequences to exacerbations, so we need to assess early treatment, and the indications for hospitalization are severe exacerbation, not having someone to help you through this, a worsening after you've initiated treatment. So we're going to be right back